So thank you all so very much for joining us today. We have had such a plethora of great information and stories that have been shared. We just finished up with our CPR demonstration from Lieutenant Monica Geiger. Again, thank you all so very much. So now we're going to transition to our next panel, which is focusing on self-measured blood pressure, also known as SMBP. For those of you who do not know me, my name is Kiva Nelson. I am a lead public health advisor within the Office on Women's Health, and I also have the pleasure of leading up the Office on Women's Health Self-Measured Blood Pressure program. The Self-Measured Blood Pressure program is a program that has been designed to leverage relationships amongst both public and private sector organizations to help encourage women and individuals to maintain healthy blood pressures at every age and stage of their lives and teach them more about what that looks like. This network of over 40 plus organizations works to empower women to take control of their heart health, works to increase access to SMBP resources and information. We collaborate to increase the knowledge and the utilization of SMBP activities within communities and organizations, as well as work to increase the collaboration with healthcare providers. So we are happy to have some of our SMBP champions and experts of the field with us today. And I will take a quick moment to provide a quick introduction for each of them, and then we will turn things over to our panelists. Our first panelist is Dr. Rachel Bond. Dr. Bond is a board-certified attending cardiologist residing in Arizona and a women's heart health and prevention specialist. She has devoted her career to the treatment of heart disease through early detection, education, as well as prevention. Dr. Bond is a fellow of the American College of Cardiology, a member of the American Society for Preventive Cardiology, a board member and co-chair of the Cardiovascular Disease in Women and Children's Committee at the Association of Black Cardiologists, as well as on the board of directors for the American Heart Association, involved in the Go Red for Women campaign. Our next panelist is Hillary Wall. Hillary Wall is a senior scientist in the Division of Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention, also known as CDC. Ms. Wall serves as the science lead for Million Hearts, a national initiative co-led by CDC and the Centers for Medicaid and Medicare Services, with the goal of preventing 1 million heart attacks and strokes by 2027. For 20 years, Ms. Wall has generated evidence-based tools, resources, and technical assistance for clinicians, public health professionals, and community-based organizations in cardiovascular disease prevention, and has been championing self-measured blood pressure monitoring for over a decade. Next up on the bill is Tim Nicolai. Dr. Nicolai is the Senior Rural Health Director for the Midwest region for the American Heart Association, where he has been for over 15 years in a variety of roles. In his current position, he works with organizations that are based in or focused on rural communities, including hospitals, community health centers, school districts, libraries, hospitals, local health departments, and much, much more. Much of that work has focused on hypertension, including creating extra clinical opportunities for measurement such as SMBP. He currently lives north of Milwaukee with his wife and 2 kids. Next up, we have Jenny Bogard. Jenny is the Executive Director of the National Hypertension Control Roundtable. She has over 20 years of experience in health behavior change, strategy development, and program design across the managed care, nonprofit, and public arenas, with a focus on expanding obesity prevention and treatment healthcare coverage. She serves on the American Academy of Pediatrics Payer Advisory Board, is a member of 2 Roundtable on Obesity working groups, and is part of the Prescription for Activity Task Force Advisory Board. And lastly, but certainly not least, we have Deborah McGrath. Deborah is the Special Projects Director for Population Health at the Health Federation of Philadelphia. As a nurse practitioner and healthcare IT professional, she has extensive experience assisting groups with successful healthcare information technology implementation projects, as well as leading SMBP initiatives, including Million Hearts participating health centers. So with that said, I will turn it over to the first of our speakers. You can feel free to go ahead and jump in.
Yes, thank you so much, Ms. Nelson, for that introduction. So as noted, I absolutely wear many hats, but today I'm actually representing the Association of Black Cardiologists. And it's really important to understand that the mission of the ABC has largely been to promote the prevention and treatment of cardiovascular disease, including stroke, in Blacks and other minorities. And the goal for that is to achieve health equity for all through the elimination of these disparities. I am so privileged because I also am the co-chair of the Women and Children in CVD Committee. And through that committee, our other mission is to improve the cardiovascular health of children and women across the lifespan. There are a lot of ways that we've been doing this. Largely, it's through grassroots efforts that focus on community. If you could advance the next slide for me, please. So a lot of these grassroots efforts have largely been centered on the fact that, as we know, cardiovascular disease remains to be the leading cause of death in the United States, but it's largely preventable. And ABC has created a series of downloadable resources, one of which we're very proud about, is an interactive guide called 7 Steps to a Healthy Heart. So these are 7 steps of what you can do to live a heart-healthy lifestyle, understanding that many of these steps help to reduce those conventional risk factors. Step 2 talks a lot about the importance of blood pressure, and we provide guidance through this step on how to self-measure your blood pressure at home. It also provides the participants with the ability to track their blood pressure on a form, and it also talks about bringing that form and the importance of bringing that form into the doctor's office. We are excited because the ABC will soon launch a revamped version of the 7 steps, and this will also focus largely on the importance of generational health. One way we're doing this is by incorporating a lot of these steps as early as possible in the pediatric population. Another popular resource from the ABC is a guide called Cooking for Your Heart and Soul. This is a plant-based cookbook which offers culturally relevant recipes and a way to help lower blood pressure and other risk factors of heart disease. Next slide, please. Now, many of these educational activities that I reviewed in detail, they largely have a long-standing relationship with a signature program that the ABC created to promote heart health. Even starting as early as the 1970s, the ABC partnered with churches, Black barbershops, and beauty salons to provide community interventions for hypertension by educating and promoting cardiovascular health practice. And these initiatives have really expanded into the ABC Spirit of the Heart health and wellness fairs, the community health advocacy training programs. And these are largely a 3-day Spirit of the Heart program that offers health screening, heart health tips, and advocacy strategies to bridge the health in terms of the health disparities that exist and make that bridge very, very small. And this includes advocating for the expansion of access to blood pressure monitors for home use. The ABC's chat program really does aim to train individuals to serve as community health advocates by engaging their healthcare and political systems to reduce cardiovascular health disparities that do disproportionately affect communities of color. And during this training, the chat trainees receive and also are coached on how to properly use self-measured blood pressure devices for their future community outreach efforts. And it's important to acknowledge that all of these chat programs are sprinkled across the United States, but it is very strategically sprinkled largely in the southern eastern states because those are where a majority of cardiology deserts exist. Next slide, please. Now, through the initiatives of programs like CHAT, the ABC also understood that trusted information matters. And with maternal health intersecting with cardiovascular health and heart disease being the leading cause of preventable maternal death, ABC took the lead and created the Faces of Black Maternal Health campaign. The goal of this campaign has largely been to hear the voices of several of our women who have experienced complications during their pregnancy and understanding that pregnancy can be a actual window to future cardiovascular health. One part of the campaign was really emphasizing the use of self-measuring blood pressure monitors. And it actually was incorporated in part of the messaging for the campaign, where many of our patients who shared their stories actually talked about how that largely impacted their pregnancy in a positive way. Additionally, there are new patient infographic resources that cover preconception to postpartum care, and we developed those and we released them this year. We recommend women initiate conversations with their clinicians about using self-measured devices as part of their overall care. Next slide. Now, lastly, ABC is actively involved in public and private partnerships to improve blood pressure control in communities across the United States. It's a founding partner of the National Hypertension Control Roundtable. It's also collaborated with other blood pressure control initiatives, such as the Release the Pressure Coalition and the Live to the Beat campaign. And more importantly, the ABC has partnered with applications like MOMI and the Preeclampsia Foundation, which provides guidance on new blood pressure tracking features during pregnancy and that immediate postpartum period. And all of these initiatives, of course, have been centered on really emphasizing that the most marginalized groups benefit the most from this. And lastly, we're very proud to have also partnered, of course, with the Office of Women's Health Self-Measured Blood Pressure Partnership Program. For any additional information, I think it's important to highlight that the ABC has a fantastic website, which is abcardio.org, and you can learn a little bit more about the very brief introduction to these programs that I just listed for you all. Thank you.
All right, I think that puts me up next. So that was a great talk, Dr. Bond, and a hard act to follow. But I just want to say thanks so much to the Office of Women's Health team for hosting this panel today. If we can go to the next slide. It's really important that you know these are my opinions and not those of CDC. And I just want to quickly mention, you're going to see some trade names on my slides. They do not imply endorsement. Next slide, please. So Million Hearts, if you're not familiar with us, we are a national initiative with the ultimate goal of preventing acute cardiovascular events. And a major focus for Million Hearts has always been improving blood pressure control. And currently, we are particularly interested in addressing inequities related to blood pressure control for pregnant and postpartum people with hypertension, people in racial and ethnic minority populations, people living in rural areas, and people with lower incomes. And one of our major strategies in this area is improving equitable accessibility to self-measured blood pressure monitoring, or SMBP. Next slide. So when we talk about SMBP devices, we want to make sure that people with hypertension are able to generate the most accurate SMBP values as possible. And accurate devices are critical, though not the only piece of this puzzle. And the U.S. Blood Pressure Validated Device Listing, or VDL, is a really great place to start for selecting devices. So devices on the VDL have been independently clinically validated by a third party, so not the device manufacturer themselves. And there's a whole bunch of technical criteria that we don't need to get into that you have to pass in order to get your device on the VDL. You can access these devices at validatebp.org. And the two arrows that I put on this slide are just pointing to, when you get to the website, how you can filter by home devices. So you're only looking at those because there's lots of different types of blood pressure devices. And also there's a new feature that was added very recently, so you can filter on devices that were validated in pregnant populations. Next slide. So in addition to accurate devices, it's really imperative that patients use properly sized blood pressure cuffs. If you use a cuff that is too small for your arm circumference, it can actually overestimate your systolic blood pressure by over 10 millimeters of mercury. And if you use a cuff that's 2 sizes too small for your arm, it can actually overestimate by up to 20 millimeters of mercury. So we've done some analyses with national surveillance data that suggest over 40% of women with hypertension require a size large or extra large cuff, using some standards that were published by the American Heart Association a number of years ago. And when we look at specifically women of reproductive age with hypertension, that percentage actually increases to over 50% who need larger cuffs. But what we've discovered as we've dug into all of this great SMBP implementation with health centers and others there is a real lack of standardization within and between device manufacturers when it comes to blood pressure cuff labels. So this a cuff that's this long could be called a large by one manufacturer, and it might be called an extra large by another manufacturer, but also in terms of the terminology that's used. And so let me go to the next slide, and I'll point out exactly what I mean. So this graph, and I know it's a little bit hard to follow, but that's okay. I'm going to walk you through it. This is from a recent manuscript that our team had published in the American Journal of Hypertension. So on the left are devices by manufacturer from the validated device listing when we pulled our data back in March. Along the top are those American Heart Association standard links that I mentioned. And then the graph shows the links that the manufacturers use for those size terms. So what one manufacturer calls a small versus what another manufacturer calls a small. And let me give you an example. So the gold line on this slide represents a patient with a 23 centimeter arm circumference, which is quite small. But if you send them to the VDL to find a device, the good news is they'll find a lot of devices that can accommodate their arm, but these devices use 10 different terms for cuff sizes, for everywhere from extra small to extra large. And you can see I've listed them all on this slide. So that's got to be really confusing for patients. And then if we go towards the other end of the spectrum, if we go to the next slide, say you have a patient who has a 43 centimeter arm circumference and you send them to the VDL. Unfortunately, they're going to find many fewer devices that can accommodate that arm circumference. 3 of the devices go by the term large for their cuff, 4 go by extra large, and 2 use the term standard. So again, adding to that confusion. Now, you may want to streamline this process for patients, and you may say, well, 43 centimeters falls within AHA's large recommended cuff length. So you may say, go to the VDL and find yourself a large cuff, a device with a large cuff. If you did that, there are actually 5 devices on the VDL who have a large cuff. You can see this by the second darkest green sort of in the middle, but those cuffs could not accommodate someone with a 43 centimeter arm circumference. So again, lots of confusion here, lots of lack of standardization, and there's some good reason for that, but I think that as a field we can do a little bit better. The take-home message is that we really need to give patients their actual arm circumference value or give them instruction as to how they can measure it themselves. Next slide. Just want to do a quick plug. We also, I only had time to cover sort of one issue here. We explore a lot of additional implementation considerations for using SMBP to control high blood pressure in women, specifically in a manuscript that we published last year in the Journal of Women's Health. Next slide. I also wanted to make sure all of you are aware of the SMBP forum that Million Hearts co-hosts with the National Association of Community Health Centers. We've been doing this for years, I want to say 7 years now. And this is not just intended for health centers, but it's a community of practice for all interested parties where we talk about all things related to SMBP implementation. So I welcome you all to join us for that conversation. Next slide. We're going to have time for questions, but always feel free to email me. Thank you.
Perfect. Thanks, Hillary, and good afternoon, everybody. I'm excited to be here today. Got a lot of information to run through, but the good news is the slides will be available for you afterwards. On the next slide, I wanted to contextualize the Heart Association's work on SMBP in the context of some of the other work we're doing on hypertension and chronic disease broadly. So you'll see our 3 ambulatory quality programs. We just recently recognized about 1,800 organizations across the country for their participation and success in one or more of these programs. And each of them is a hub of additional resources that you or your organization might benefit from. On the next slide, we'll dive a little bit deeper. My role within the Heart Association is specifically focused on rural health and the disparities that are often faced by those communities. And so this slide just does a pretty decent job of using the America's Health Rankings, which is a great website for looking at different disparities of data. You can see some of the gaps between metro and non-metro areas that exist for hypertension, in particular, about a 7 or 8% difference in the identified rate of hypertension. On the next slide, so Target BP, which is a joint effort of the AHA and the AMA, is focused on this MAP framework, which says we need to measure blood pressure accurately every time. We need to act rapidly to diagnose and treat hypertension. And we need to partner with patients to self-manage and self-monitor. And I really emphasize when I'm working with organizations that SMBP is fantastic, but it works best when happening in an environment where blood pressure is being measured accurately every time, so that we can ensure that the right patients are getting access to and being enrolled in SMBP. And so on the next slide, you'll see some of the impact that our Target BP program has had on the accuracy of measurement as reported by organizations. So there's a number of evidence-based activities that contribute to accurate blood pressure measurement, things like annual staff testing or annual staff training of proper measurement technique. And you can see among our organizations in that third kind of set of columns there, that's gone from 67% of organizations to 85% of organizations. And so what we've seen is that by systematically approaching some of this, we can help move the needle for participating organizations and drive the conversation. What's exciting, and then on the next slide, you'll see we're moving beyond focusing on that accurate measurement and trying to add similar metrics around several other criteria. So the act rapidly, the partner with patients, will be evaluating and helping organizations assess their ability to adhere to these standards for self-measured blood pressure programs. Things like establishing a measurement schedule, receiving and averaging those readings to inform decisions. And then we'll also be looking at equitable health outcomes with some standard evaluation processes. On the next slide. So many of you are quite familiar with these, and they've been alluded to by other panelists already. But some of the benefits of self-measured blood pressure are particularly relevant when you're thinking about improving the accuracy of diagnosing hypertension and trying to rule out mask or white coat. When you're thinking about managing patient blood pressure through the use and titration of blood pressure medication to evaluate whether those interventions are having the intended impact. And then kind of that combination of things can help patients adhere to treatment as they see the benefits of a pharmacotherapy, for instance. They can hopefully continue with that. On the next slide. So I do, as mentioned, focus specifically in rural settings, and what we've come to learn through our focus on the National Hypertension Control Initiative, which was an effort through HRSA with 350 community health centers. I had the privilege to work with a number of rural health centers in that. Many of the challenges are present across the landscape, whether they're an urban or a rural setting, but they're often exacerbated or hyper-focused in the rural settings. And so when we think about opportunities to reduce barriers for patients to participate in self-measured blood pressure, you offer enrollment and we want them to say yes, and we want them to engage in that. In the rural setting in particular, it was important that we make that process as easy as possible. And so organizations I worked with, knowing that their patients might be coming 45 minutes or an hour away, they would offer to enroll somebody in SMBP, and they would immediately, whenever possible, walk them down the hallway to do that right away and save the patient a trip back in. When we think about difficulties with technology integration, one of the things we learned through the National Hypertension Control Initiative is that all of these devices don't link with all of the EHRs in quite the nice way we would like them to. That was particularly acute in rural communities where internet coverage is less and it's older population that's less familiar. So it was incumbent on the organizations to ultimately have backup plans and not let the technology gap become a gap in offering that care. And you'll see some of the other factors that we consider too, engaging the entire care team. I think as staff shortages were present in many of these rural care settings, it was important that those gaps not become a barrier in and of themselves for patients. And so how could you get the pharmacist involved in the conversation around SMBP and re-emphasize what had been talked to the parent, what the patient had heard from the nurse or other staff on the team. And then on the next slide, one of the things we've also done, I mentioned in my introduction, extra clinical work. So while we'd love in many ways for every patient to have a monitor at home, we know that's not always going to be realistic. There are a number of barriers to that. So the Heart Association has started working on these community hypertension hubs. And we heard a little bit of that the ABC has done. But we're facilitating these in churches and libraries, employers, and more, where blood pressure monitors are pre-positioned in the community where people are gathered already. And they can check their blood pressure, again, using those validated devices and the right education materials, but then being referred back to clinical linkages. And certainly this is relevant in rural settings where the nearest clinical setting might be 45 minutes away, but it could be useful in more urban settings as well. And I think maybe one more slide I have. I was going to make sure we highlighted the validated device listing, but Hillary did a fantastic job of that. So it is now, additional search features, which is fantastic. And so we'll skip over that. A couple of helpful resources through that National Hypertension Control Initiative. We did come up with these patient education workbooks. These images are downloadable when you get the slides. So there's one in English and one in Spanish, as well as our SMBP Quick Start Guide out of Target BP. And then I think the last slide, besides my contact information, is a new report that came out about implementation strategies to improve blood pressure control in the US. I believe, if this is the right one, that Hillary is one of the authors of that. So you've got the experts here. And we're hosting a webinar kind of in that topic on November 2nd that I would encourage you all to consider attending. And there's my contact information, so I can certainly put you in touch with my colleagues across the country for those who are not in the Midwest. Thank you very much.
All right, so I think I'm up next. So first of all, I want to thank my panelists, my colleagues on this panel, because many of you, I think all of you, are actually members of the National Hypertension Control Roundtable. As Kiva mentioned, my name is Jenny Bogart, and I'm the Executive Director. Next slide. So the roundtable works a little bit differently than some of my colleagues on this panel's programs, in the sense that we're not creating programs at the roundtable. We're bringing all the key players together to really elevate and scale their work. And as you see on this slide, our vision is a simple but profound vision to me, where we really truly want to extend healthy life for all. One of our core values is focusing and advancing health equity. As many of my colleagues have already pointed out, that's a huge, huge priority for us. Next slide. So I just want to point out, as Dr. Bond mentioned, the ABC is one of our founding partners, as well as Dr. Madale Uganini is one of our amazing co-chairs. I could not do the work that I do without her guidance and leadership. In addition, we have Dr. Jaime Murillo, who's at United Healthcare, and that was very intentional in the sense that we really want to bring multiple sectors together to address hypertension control in the U.S. Next slide. So some of the activities that we do in order to achieve this goal is we have fireside chats. We have a lot focusing on SMBP programs, where we invite people across the country to talk about what they're doing. So state health plans, community health workers, social workers, you name it. We really want to bring everyone together to continue the conversation and show everyone the opportunities to collaborate and partner together across sectors to achieve this goal. In addition, we publish newsletters where we share our members' programs and activities. So if anybody would like to sign up and get the word out and all the great work that you're doing, please let me know. We use this newsletter really as a platform to really lift up all the wonderful things that are happening. But I really want to focus on the first bullet point, which is the payer task force. What we recognized a while ago is that there is so much great work happening across this country, but we really need to start engaging the private sector as well, including payers. So we launched a payer task force a little bit over a year ago, where we invited payers, and I'm defining payers as insurance companies at this point. We invited payers to a task force to really talk about what they can be doing in terms of reimbursement. That conversation evolved into validated blood pressure devices, as all of my colleagues have mentioned. We then invited the AMA to join the payer task force. They shared the Validate BP program that they lead, and the payers responded saying, this is great, but we need you to speak in a language that we speak. So the AMA actually went back and created a toolkit for our payers that they can then argue it internally at their organizations to really push for reimbursement. As some of you probably already know, there was an article that was published earlier this year that showed that on Amazon, There are many, many products that have 5-star ratings from consumers that are not validated. And this is a really big problem. We need to make sure we're getting the right devices and the right size cuffs into people's hands, in addition to training them on measuring their own blood pressure. So we're really trying to fill in the gaps that currently exist between all of the work that's happening on the public health side to how that translates to businesses, employers, and payers. And I also want to mention, we are not forgetting about Medicaid and Medicare. That is also something that we are going to try to tackle this year. Next slide. So I also just want to take this home on my last slide. Is to talk about promoting the validated blood pressure devices. So Dr. Q Ree is on our steering committee board, and he came up with this view of there are 7 key points onto how we can truly move the needle around pushing and advancing validated blood pressure devices. So as you see on this slide, these are all the different areas of focus for us moving forward, and how do we engage people in each of these areas to really, again, move that needle forward to ensure that everyone has access in all communities to proper devices and proper size cuffs. I know I have one more slide, Kiva, if you want to just advance. Just as a programming note, I think there's one more slide. As a programming note, oh, no, okay. Well, anyway, Dr. Yvonne Commodore-Mensah is going to be our next co-chair. So we're thrilled to have her be our co-chair next year with Jaime Murillo as Dr. Uganini rolls off. Call out to anyone out there to join the roundtable is free. You just have to sign up. But we really want to continue this conversation on a national scale and really promote all of the wonderful work that everyone is doing on this call. So thank you very much. I'm going to pass it over to Deborah.
So thank you. And I've gone low tech. I don't have slides for you today. You're just going to get to hear me talk a little bit about our programs. But before I do, I want to thank you for including me. And also, Kiva, can you tell me how we're doing on time?
We have 11 minutes, so we're going to go into some questions after.
I want to make sure there's some time for questions. So I'm going to tell you how where this all started for me and where we are right now. In June of 2020, I was watching hypertension control rates just drop through the floor during the middle of the pandemic, or the beginning, I guess, of it. And what I realized at that point is that for all of our, many of our health centers that I was working with, they didn't have blood pressures in the chart, which is partly why those blood pressure control rates were going through the floor. So at that point, I had the privilege of working with A Million Hearts, and we started putting self-reporting blood pressure cuffs in the hands of patients, and began to see, number one, some of the challenges of that. Number two, some of the huge rewards and benefits of that. And what it has led to is where we are today. I support many health centers, I don't even know how many it is at the moment, in their implementation of SMBP, and I've coined it SMBP Plus, because when we work with health centers and other practices on this, what we are really talking about is a process of enrollment, monitoring, intervention, which really means intensification of treatment, and improving our own healthy actions, as well as moving to stabilization and graduation from the program. That is really the cornerstone of SMBP, as opposed to remote patient monitoring. SMBP should have a beginning, a middle, and an end. Not to say that it won't restart, but it should have a beginning, a middle, and an end. So in terms of some of the things I just want to put a point on that my colleagues have already talked about, the EHR integration piece is really challenging. Hillary and I sit on the, we're trying to create standards for that integration. Anybody who has questions about that, should feel free to contact one or the other of us, and we can at least give you the lay of the land where things are right now and what some of the challenges are and how you can be a voice with your EHR vendor to get this moving forward, because they are tired of listening to me, trust me. Go on about this. I think the other thing I want to talk, I put in the chat the FCC ACP program, the link to that. Tim talked about the challenges of internet access and that sort of thing, also device access in terms of tablets and phones. The ACP can be really, really helpful. It's not perfect, but it does offer an opportunity for low and no cost internet access, as well as devices in some cases. So I just wanted to put a plug in for that. And I'm also putting in the chat a link to an implementation article that Hillary and I and Meg Mador and another colleague, Raj, worked on and was published in March. It does give you this sort of, cookbook approach to implementing it, should anybody be struggling with that or want more information about it. And finally, I just want to make the point that one of the huge rewards of working with these programs has been the provider satisfaction that we've seen, where providers are like, yeah, I have actionable data now. I don't have to say the patient was running to 6 buses, just had a fight with their spouse, was just frustrated, wasn't sat long enough in the office. We are actually getting actionable data that is allowing for in between the visits, because, once the patient leaves the suite, like, what happens then? And also the incredible patient satisfaction. Patients just love knowing that somebody is looking at their blood pressure values on a regular basis and is reaching out to them to say, okay, where can we work together and look at that high salt meal you had the other day, because you go to the same restaurant every Monday, so every Tuesday your blood pressure's through the roof. Can we look at that menu together and come up with something that actually will work for you? So SMBP is not easy. It is incredibly valuable. It is incredibly rewarding. And I hope that you'll reach out to the extent that any of us can be helpful in helping you move your SMBP forward.
Thank you. Thank you so much. I'm sorry, Deb, did you have something?
No, I'll hand it back so that there can be questions.
Oh, thank you. We appreciate you. And we have gotten a lot of engagement, a lot of questions. So I'm going to try to dive right in. The first of which was directed directly for Hillary Wall, but I welcome any of you to chime in after Hillary responds. And Hillary, the question was, please provide your take on wrist cuffs or using the lower arm to take blood pressure when a large cuff is unavailable.
Great question, and thanks for asking that. So the party line is we really recommend upper arm automatic devices for most patients. That's where the science really is. And we find that they're fairly easy for patients to use. However, for patients, a subset of patients who have very large arms or very conical arms, so that, it's not a straight blood pressure cuff, is hard to fit on them properly, a wrist cuff can certainly be appropriate for them. What we find, though, is that there's actually some user error there, because you have to have your wrist at a high enough level. Kiva, thank you for dropping that link. If you are using wrist cuffs for patients, there is a great guide from Target BP that shows the patient exactly how their arm should be positioned to properly use the cuff. In terms of the devices that are now sort of mid-arm, that's sort of an evolving science. There's a lot of new technology related to blood pressure measurement that is coming down the pike. Many of us who are on this call and colleagues we work with are trying to stay on top of some of these. Right now, we're not recommending those devices. That doesn't mean if I'm back here next year, maybe I'll be saying something different to you. But for right now, upper arm automatic devices whenever possible, or wrist devices with proper technique for patients who really need them.
Anyone else want to chime in on that before we move on to another question?
There are, I think, 2 or 3 wrist cuffs on the validated device list now, last I saw. So if you do need to go that route, would definitely encourage still starting with that as your basis of information.
The one thing I would mention around wrist cuffs and cuffs in general is really encouraging people to document in the patient's chart what kind of cuff they were issued, what size cuff they were issued, and to come to an agreement on what that enrollment and education process looks like. I strongly recommend, having, if you can have the cuffs there, and doing a teach back with the patient so that you are looking at what the patient is getting on a blood pressure reading and comparing that, because you want it to be, that's part of the validation process of the cuffs that are being issued, but also you use your brain, right? If this blood pressure is way out of range from what you've been seeing with that patient, it requires sort of looking at that, making sure you've got the right size cuff and that the patient really does know how to use it.
Okay, great, thank you for that. There was a question directed at Tim. With your work in rural settings, is there any opportunity for you to share some of your thoughts on addressing the digital divide, particularly in Native reservations, Amish communities, etc.? Could you weigh in on that?
It's a great question. We did some work with an Amish community in Missouri last year, and there was some concerns because they weren't able to use the battery operated devices in the same way that we would generally encourage. And so we actually started looking if anyone had solar powered devices anywhere in the world, and none that had been validated to any degree of accuracy per se. So, it was really about trust. And so we did have some people on the ground there in Missouri who could build that trust with the community. And they started to move the needle in terms of their comfort and thinking about and talking about and measuring their blood pressure over the course of the 10 months that we had that program going. And so I think I think Deborah kind of alluded to this too, that there's that opportunity through SMBP anywhere it's happening to build that relationship, understand who the patient is and where they're coming from, and help work through those challenges that are affecting their real everyday lives, with SMBP as a tool to help educate them further and move the needle on their hypertension.
And I'll just quickly add, if anybody's really interested in looking at broadband availability across the country, we wrote an article a couple of years ago now that just put in the chat. We published some maps that overlay self-reported hypertension at the county level and broadband availability at a number of different levels. So just take a look there. But it is a challenge, not only for SMBP, but also things like remote cardiac rehab programs and lots of other telehealth technology. So I think there's lots of national organizations and agencies that are really trying to attend to this, especially for Native populations and states like Alaska that are very, very rural.
I will also promote the concept of digital navigator. We've been able to employ a digital navigator at the Health Federation. She has been incredibly helpful with patients to help understand what their capabilities are, what they need, what the gaps are, how to fill those gaps. And she's an expert, for example, at that ACP program, and really knows that like the back of her hand. It's been a very helpful role, and we're promoting that role through AmeriCorps, just so folks know that, and trying to build out that workforce.
Thank you so much. A question for Dr. Bond. Would you please share with us a little bit more about the steps that your work is taking you in regards to addressing generational health? You mentioned that during your talk.
Yeah, so a large part of the Women in Children's Cardiovascular Disease Committee was to understand that with cardiac disease being largely preventable, the earlier on we hone in and hopefully prevent a lot of those conventional risk factors like high blood pressure, high cholesterol, obesity, the higher likelihood we will have success in preventing heart disease in the future. So with the 7 steps for a healthy heart, it's a resource tool that talks a lot about how one should go to the physician and the clinician, get their blood pressure checked, but also get their other conventional risk factors checked through blood work. How you could also incorporate the spirituality of it and understanding that a large driver oftentimes of these health disparities are not the biology of it, but it's more the social aspects and the psychosocial aspects. So part of the steps we also talk about is being aware of that sort of community support and starting that as early as possible. One thing that I think that we are really trying to hone in on also is providing education to the community on when they should be having their children screened for these risk factors like elevated blood pressure and cholesterol, because oftentimes what we're noticing is that pediatricians are not routinely checking based on the fact even when they have strong family histories of it. So I'm very fortunate that I work with a pediatric cardiologist who focuses on prevention. So through our guidance and these 7 steps, we're giving the community a better understanding as to when their children should be screened, what that screening would look like, and more importantly, what questions they should be asking their clinicians when they're in the doctor's office or the clinician's office and they're with their child.
Thank you so much. The last question I'm going to direct at Jenny. Jenny, if you wouldn't mind sharing with us a little bit more about the great work that is done within the Hypertension Control Roundtable and some of the fireside chats and how you really work to engage and amplify the messaging.
Yeah, so, as I mentioned, the fireside chats is just one activity that we do at the roundtable where we invite members and non-members to really talk about their programs, the outreach that they're doing in their communities. In the last year, I think we hosted about 5 or 6 webinars where we talked on brain health and hypertension. We talked about SMBP. We talked about community health workers and how we really need to have an extension of the healthcare team beyond just what happens in the exam room. And really what this is, it gives programs, even if they're small. We had barbershops on our fireside chat talk about the work that they're doing. We've had bishops come on to talk about the work that they're doing, really trying to shed a light into all the great work that's happening on the ground in all these communities. And really what we're trying to do is spark or inspire people who are listening in on this fire chats of what they could be doing in their own organizations, within their own partnerships. So we've had a lot of organic conversations happen after these fireside chats where organizations will reach out to each other, or they'll look internally in their own organizations to see about expanding or creating a program similar to one they just had. So I will put a shout out there if anybody has any programs that they would like to share with us, or any topic areas that they would really like to have us focus on. I'm always open to listening to great ideas and encourage you to reach out to me.
Thank you, Jenny. And thank you all to all of our panelists for taking time out of your busy days and schedules to join us and lend us your expertise. I would invite you to continue to drop any helpful resources or anything else that you'd like to add to the chat. For any of our summit participants, if you haven't done so, please look into the chat. There's some extremely helpful links and resources there that you may decide to refer to later. So thank you all so much again. And I will now turn things back over to Gage Dalton. Thank you.
Thank you.
All right. Thank you, Kiva, and a huge thank you to the members of OWH's SMBP program who just shared. It is incredibly fitting that we just heard about the benefits of self-measured blood pressure monitoring and the future directions for SMBP, because now we are heading into a panel of presenters who have successfully gotten blood pressure cuffs into the hands of those who need them most in their communities. This panel is made up of some of the awardees of Phase 2 of the HHS Hypertension Innovator Award Competition, a challenge from the Office on Women's Health to identify innovative methods of blood pressure monitoring and follow-up in women during pregnancy and/or postpartum. And our panelists for this discussion today are Dr. Veronica Gillespie-Bell from Ochsner Health, Dr. Sarosh Rana from University of Chicago, Dr. Danielle Dury from Lehigh Valley Health Network, Eleni Tsigas from the Preeclampsia Foundation, and Dr. Elizabeth Langan from University of Michigan. And thank you all for joining us today. It's a pleasure to have you on this panel. And just kicking off, could each of you give a quick overview of your projects and how that is related to getting blood pressure cuffs into the hands of women? And Dr. Gillespie-Bell, I'll ask you to kick us off with some of the work you are doing with remote monitoring in your state.
Sure. Thank you all for allowing me to join you today. So we have a program here at Ochsner called Connected Mom. We've had it in place for several years now, about 7 years. With this program, our moms are able to opt in. They get a blood pressure cuff that is Bluetooth enabled, as well as a digital scale that's Bluetooth enabled. And throughout the program, they take their blood pressures. It uploads to the electronic health record through their Bluetooth enabled devices in their phones. And then we, on the provider side, receive those readings. If the patient has a reading that is abnormal, the patient is alerted to contact the office, as well as the office is alerted. And if it's after hours, the patient's instructed to go to labor and delivery. And if the patient doesn't take her blood pressures, she gets text messages at very annoying times until she does. So it definitely has helped with compliance. With getting those blood pressure checks. It's also helped us diagnose preeclampsia in between routine visits. It's really been a great benefit in terms of hypertension and just being able to bring care to patients, especially at times when patients have not been able to come into the office. COVID-19, being in Louisiana, we have evacuations because of hurricanes. All of those times has been a great way for us to stay connected to our patients.
Thank you. And Dr. Dury?
Hello. So our program is actually somewhat similar, but mostly focused on our postpartum women who had preeclampsia or hypertensive disorders of pregnancy. And ours is called the Continuous Ambulatory Remote Engagement Services, abbreviated CARES program. And it's our remote blood pressure monitoring service that we enroll all postpartum women who had preeclampsia during their pregnancy. They're all given a Bluetooth enabled automated blood pressure cuff. They're instructed on how to use it when they're in the hospital, and they're instructed to check it several times a day at home. We actually have a full CARES nursing team who take care of our postpartum patients, but this program is actually bigger within our network, who monitor patients who had COVID, post-CABG, and other indications for remote monitoring as well. And they monitor the patient's blood pressures every day using an algorithm that the maternal fetal medicine division has given them. And for minor things, they check in with the patients, make sure they don't have symptoms of anything. And anything that's more concerning or symptom related, they contact the maternal fetal medicine office, and then we reach out to the patient to manage their postpartum blood pressures. Send them to the hospital as needed, but a lot of times we can manage their medications and hopefully keep them out of the hospital, but only readmit the patients who need it. And that actually increases a lot of the blood pressure compliance postpartum, instead of them going back to the office, several days after delivery, a week after delivery when they have a newborn, which when we had started the program, not many patients were going to the office. And so this really improved our compliance significantly. So we're actually starting to expand this to some antepartum patients who have really high risks like cardiac disease and renal disease, but right now it's mostly our postpartum patients.
That's great. Dr. Rana?
Hi, everyone. Thank you so much. Nice to see everyone. So I'm Sarosh Rana. I'm the section chief of maternal fetal medicine at the University of Chicago. So I would say yes, our program is very similar to Dr. Dury's program. It is called STAMP Hypertension. So essentially stands for Systematic Treatment and Management of Postpartum Hypertension. A few things I would like to point out. Similarly, we are actually, so it's a program that has a lot of, I want to emphasize different components. So we have nursing, which is essentially driving this, especially in the postpartum unit. We call it a bundled approach because a large emphasis, especially early on, we paid on the physician as well as the patient education. So we created this like whole system around which every patient gets systematic education, and at the time of discharge, they get discharge instructions. We are handing them blood pressure cuffs, which are now Bluetooth enabled. So the whole program is now telemonitoring, and it's actually funded by the University of Chicago. It has no cost to the patient. I think one of the few things that I learned along the way, and since I'm an MFM, is a little bit perhaps easier for me to do, is that we also updated all the protocols for readmissions. We kind of updated the protocol of how the patient, if they have to go through the ED, they're not going through the ED, but if they were to be in the ED, we updated those protocols. We kind of, the other thing we did was we created these postpartum hypertension clinics. So these are the clinics where, so all patients, regardless of their primary insurance, whether you're Medicaid or not, whether you see a general OBGYN or an MFM, every single patient who has any kind of hypertensive disorder pregnancy, during pregnancy, and delivers at the University of Chicago goes through the system. So everybody gets this telehealth appointment at 7 to 10 day, which is essentially run by the MFM PAs under MFM supervision. So everybody gets this appointment that is made before they leave, and it's a telehealth appointment. We also have 24/7 surveillance. I'm pretty sure you guys have it too for the telemonitoring. And we actually sat down with this company, which is called HRS, which is Health Recovery Solutions, and created escalation protocols which are specific to postpartum hypertension as to when the patients are being escalated, and when they come in is essentially severe hypertension in any of the survey that they get. So similarly, like Dr. Jury, we had great response. In fact, we looked at the data. It's already published now, 2 papers. Is that before we did anything, the rates of postpartum hypertension follow-up at our institution, for example, among Black women was 30%, and now we are over 86%. So it's been a tremendous, and it's been like a tremendous program that has reduced the disparity gap between white people following up and Black people following up. So it's and then we have done several surveys about patient satisfaction. So it's been quite a I would say successful program.
Thank you. And Eleni?
Well, I figured you'd put me last since I'm the one who is not the doctor in the group. One of the things that I guess I'll start off by pointing out when I'm going to be talking about the Cuff Kit program that we're doing. All the programs that are being highlighted in this session are, of course, really focused on pregnancy in the postpartum period. And I think one of the unique things that we all are recognizing is that pregnancy is a unique time point in a woman's life for oftentimes introducing the idea of self-measured blood pressure. It's often the first time it's routinely done to her in a way that truly affects how that pregnancy is going. Obviously, being with the Preeclampsia Foundation, that's why we're having this conversation, because of preeclampsia and hypertensive disorders of pregnancy. So I think that's an interesting point, because a lot of the sessions today are looking at blood pressure in women across their lifespan and how it affects different time points. And I think what we're increasingly seeing is that this is not just something that should be done in the doctor's office or the midwife's office during prenatal care without really engaging the mother in that process. At the Preeclampsia Foundation, we are super adamant about patient empowerment, and that really means making sure she understands the signs and symptoms of preeclampsia. Blood pressure is the most important clinical sign. So that's a big driver for why we're involved in this program. So briefly, what we are doing with the Cuff Kit program, unlike all the other panelists here who have implemented wonderful programs in a specific geographic area, often associated with their state or with their academic institution, the Cuff Kit program is something that we are making available across the country, and we are working with a number of healthcare providers in various settings: hospitals, clinics, home visiting programs, just a number of different settings where a pregnant or postpartum mother might have an interaction with some kind of a healthcare provider or community health worker and be able to get a blood pressure cuff. The cuff kit itself is a pregnancy validated device, and that's an important distinction because we've heard a lot about validation, and even beyond validation is what's been validated for pregnancy. We offer it in a number of different sizes because we know that cuff size is super important. We also offer a number of different ways for the blood pressure to be logged. Everything from super manual, where there's actually a piece of paper included in the kit with instructions about how to log your own blood pressure. We think there's actually a value to that engagement, that patient engagement with that tracking. But it also is a Bluetooth-enabled device, and those numbers can automatically be uploaded to a free smartphone app that comes with the device. There's also an opportunity for those who are working off the Epic EMR system to have all of this data sucked right into the Epic EMR for closer monitoring by healthcare providers. The device and the kit is not just the device and the batteries, but it's also the education materials. And that's a really key distinction. We know that that opportunity to deliver a device to a patient with good patient-centric education is key to the success of this program. It's a teachable moment. You have to use some of those health communication strategies like teach back, and that's a key part of it. You need to make sure that it is offered in a language that the patient understands. So our cuff kits and all of our materials are available in multiple languages. So there's a number of sort of basic health communication strategies that go along with this kit. We also include a rubber bracelet that says still at risk, and this is an opportunity to give this to moms at discharge after their birth so that they and any healthcare providers that they interact with will know that they're still at risk for some kind of a postpartum hypertensive event. This serves to educate not just mom, but anybody that she comes in contact with. So a couple of the other key features of this program, by the way, at this point in time, we have distributed over 25,000 of these cuff kits in almost 20 states, working with over 200 different provider or sites. That has given us a wonderful insight into how this works across the country in different settings with different kinds of providers. And one of the key features of this program is that we've really infused it with a healthy dose of research. We do have it under an IRB. We are working with a number of different research experts. And in fact, we've already published some of the first data out of what we're calling the first phase of this program. And I'll just really quickly share it because I think it offers some insight into patient and provider acceptance of SMBP, a theme that has been recognized on some of the other panels. But in that study, again, sort of the phase one of this data, it was analyzing 2,900 the distribution of 2,900 kits into patients' hands, and that was in 179 sites in 14 states. We have asked our providers, regardless of the kind of providers, to prioritize the highest risk women. We know this is a limited asset, and so we've asked them to prioritize the highest risk women. We're super happy to see that as a result, about over 1,100 of the kits were distributed to Black patients, over 1,000 to white patients, 500 to Hispanic patients. We also have an optional patient response survey, which has given us a little bit of insight about how the patients feel about the use of these cuff kits. With the patient surveys, most of the patients found the cuff kits very valuable or valuable, basically 68, almost 80% in total. And the providers, almost 75% of the providers felt that the cuff kits actually influenced their patient care. So we're in the process of working on two other major studies. One is in the state of Missouri, and the other is with the Healthy Start program, where we distributed to 15 Healthy Start sites. And so we're eagerly analyzing and collecting, and then we'll be analyzing that data to be able to report on and how that's working. I think one of the other key features of this cuff kit program is that we made a deliberate decision to not distribute it directly to patients. We wanted to go through some kind of a provider, because if you put this information into the hands of patients and they don't have a place to go report concerning blood pressure readings, if they don't have that linkage to healthcare in some way, that's not a good situation. So we really wanted to give this as a tool to providers to enable their patients to have the home blood pressure monitoring. This all arose out of COVID. We had providers, starting with Dr. Rana and several others, who came to us and said, oh my gosh, all my patients are having to do telehealth. And we know that to screen for preeclampsia, looking at blood pressure is critical. How am I going to do this with them at home? And so we quickly mobilized. I know the key word for COVID was how quickly can you pivot? And I'm really proud of my team, because we pivoted within a couple of months and were able to source large quantities of pregnancy validated cuffs and to put the whole program into place. So it's been super exciting to see not only that it helped during the pandemic, but we know that this is here to stay. We're in the process of doing these research studies and collaborating with a number of different teams to collect the evidence base for what we need to analyze those findings and to really, I think, move toward a new standard of care in prenatal and postpartum monitoring and management. I call it the 3 M's. We need to measure, monitor, and then manage. And all of that needs to be able to be done remotely if possible. So that's just a quick overview of the Cuff Kit program, and happy to get into more details in our discussion.
All right, and Dr. Langen.
Excellent. Thanks so much. It's so lovely to hear all these different innovative ideas, which are, variations on the same theme. Our program is a variation on this theme and trying to get blood pressure cuffs to pregnant people, certainly with a focus in the postpartum period. And we've done a couple things which I think are similar and some which are a little bit unique to the other programs. So one thing that we have done is, my particular team are the high risk or maternal fetal medicine doctors, but we also partner with some of our generalists who are more experienced in policy and advocacy work. And they worked very hard in the beginning of the pandemic. And in fact, this afternoon are also testifying in front of the State of Michigan Assembly to encourage to make it mandatory that insurance providers cover blood pressure cuffs for pregnant people. So they were successful in just convincing several insurance companies in the early pandemic. And now we're partnering with the state legislation to try to make it a mandatory feature of insurance that's provided in the state of Michigan. So partnering with those folks has been super helpful for us, because while I'm really great at being an MFM and managing blood pressures, I'm not so good at that policy advocacy work. So having those partners has been great. The second thing that we've done is branched out and really brought in some of our midwives to help us with this care. On our labor and delivery unit, our midwives do a lot of the postpartum rounding, and we know that they have a really great relationship with their patients. So our remote monitoring blood pressure program, which is also in the postpartum period, it is, from the patient's point of view, text-based. They just get a text message on their phone. So something that they're really used to using, something they're using all the time. They text back in their blood pressures and symptoms. So they have that feedback where they have to write down what the number is, but it's in a way that's as easy as possible for them. And then the numbers come into an Epic flow sheet. So for the providers, it seems like it's just part of their healthcare system. And those blood pressures are actually managed by a team of midwives at our institution. And we went back and forth about, should it be physicians or nurses or midwives or who should do this? And we feel like the midwives provide a really nice, unique perspective. So we have protocols like everyone else about how to titrate up and down antihypertensive medications in the postpartum periods. If people have concerning symptoms or blood pressures, our midwives are able to speak with them and can write prescriptions as providers. And oftentimes the midwives will say, gosh, well, she also was feeling kind of depressed. And so they'll do screenings for postpartum depression or bleeding differences, and can actually, people, to the point that someone was making earlier in the self-monitoring blood pressure talk, make people feel like there's someone in their healthcare team who really cares about them and is reaching out. And we've been able to form a lot of great relationships. So instead of feeling left alone to manage their blood pressure, they actually feel like they're getting a little bit of extra care. In addition to our folks with hypertensive disorders of pregnancy, we also include people who have other forms of cardiovascular disease for whom getting postpartum preeclampsia would be especially problematic. So people who have aortic disease and other types of things where we're worried about them get included in the program so we can pick up the postpartum preeclampsia diagnoses a little bit sooner and bring those folks back. And just like everyone else in this call, we also hand out blood pressure cuffs in the postpartum period to folks who had not been able to get it antepartum. And for us, it was a cost issue that we were really easily able to convince our hospital management that it would save them money, because this helps people get out of the hospital a little bit more efficiently. It saves money in follow-up visits because people are being managed at home. And so for other folks who are having a hard time convincing their hospital leadership that this is cost effective, we can help you do the math. It's pretty easy to convince them that this is not only in patients' long-term best interest to have access to these devices, but it for the hospital helps them financially as well.
This is all just amazing work. And moving on, what strategies have worked for you all in getting patients to adopt self-measured blood pressure? Many of you discussed getting cuffs to women, but how are you getting them to record their numbers?
So I think, I guess if we go in the same order, I think for our program, Connected Mom, because it is throughout the pregnancy and in the postpartum period, the initial is getting them to be engaged and getting them to enroll in the program. It's no cost to the patient. The hospital absorbs the cost. But it still takes I think the relationship with the patient and the understanding of why it's beneficial. Again, for our patients, when I'm telling them about Connected Mom, I explain that it allows us to monitor them more closely. It's a way of us bringing care to the patient instead of making the patient come to care, which I think is so important when we think about the different barriers to access to care and social determinants of health. Our program also is built into it is a virtual telehealth component as well. So there are many selling pieces to the program, but it still takes having that conversation. For me, as the medical director of our MMRC for our state, where I review all of our maternal deaths, I bring that into the conversation and I explain how cardiovascular conditions are the leading cause of pregnancy-related deaths in Black women in particular, but still one of the leading causes overall. And I explain the importance of the blood pressure monitoring, and that really being one of the biggest benefits of our program. And so that, after saying all of that, the patients are usually convinced, and they do want to enroll, and they do feel as I think Dr. Langen said, they feel like someone is watching them more closely. Because if you think about prenatal visits and how infrequently we actually see patients, they feel like someone's watching them more closely. And especially when we talk about the postpartum period, where it's generally been our practice in the United States to not see patients until 6 weeks postpartum. And we all know now from our mortality data, a lot of stuff happens between the time you deliver to 6 weeks postpartum. And so getting them prepared for that transition and how this program will benefit them all of that, I think, has helped with the enrollment. And in the design of the program, as I mentioned, if patients don't report their blood pressures in a certain time frame, they will get text messages until they do. And so that has been that's been a great driver for patients to be compliant. And we still have barriers and we still have challenges, as I think we have to always acknowledge with telehealth that there are going to be challenges with digital health literacy, with access, with just the uptake. But working in some of those things like the text messaging, all those things help for the patients to be compliant with being able to take their blood pressures. And we actually have looked at this in our patients that have a hypertensive disorder of pregnancy, and looking at our moms in Connected Mom versus usual care. And those patients, specifically in the postpartum period, take their blood pressures more frequently. I think all of us could probably see that with our programs. They take their blood pressures more frequently. They take them in the time frame that we recommend. And I think that's super important as the recommendations have changed from ACOG and AIM and supported by SMFM. For those patients that have severe hypertension, they're supposed to have a follow-up blood pressure within 3 days of discharge. And to have any of the programs that we are discussing here and to be able to be in the benefit of your own home, taking that blood pressure, we're talking about 72 hours after leaving the hospital and being able to take that blood pressure. I think all of those things have encouraged our patients to be able to enroll in the program and then be compliant with taking blood pressures.
I would agree. I mean, I think most of it's education. I think educating the patients from the get-go as to the importance of the close blood pressure follow-up after they deliver, at least since, again, ours is mostly postpartum. You know, our program is also more of an opt-out type program. We enroll all of our postpartum patients with preeclampsia, and on occasion, patients will say they're not interested in participating, and then we do set them up to be seen in the office. But, you know, we also educate them on the benefits of the program, that then they don't have to come to the office within a couple days. We obviously go through all the education of the importance of close blood pressure follow-up, postpartum. And I think in today's day and age, a lot of patients really do appreciate the ability to sort of have some of the virtual visits and the follow-up over the phone and things like that. And so the fact that they know we can, if they're stable, manage their blood pressures and adjust medications and things remotely without them having to always come for visits, they're really happy about that. And, I could tell you, just as a knee jerk, there's only a few of us in my office will do most of the management. So we're very comfortable and less likely to automatically just, instinctively send people back to the hospital, where previously there were a lot of people in the office that were managing blood pressures who don't see that many. And the second somebody would come in with a mildly elevated blood pressure, they automatically sent to triage, and so 50% chance or higher, probably they're going to get readmitted. And so trying to educate patients, we're really trying to keep you out of the hospital if you don't need to be there. This is really going to benefit you in the long run. I think that they're more likely to adopt it. Also, a lot of them aren't able to get their own blood pressure cuff. And so giving them the cuff is an also added benefit. Ours are Bluetooth enabled. So we keep them in the program until 4 to 6 weeks postpartum. And then if they're, stable, their blood pressures are well controlled, then the program sends them a little box to send the modem back, but they get to keep the cuff, and it continues to work. It just doesn't transmit to the EMR any longer. So they will continue to have a working blood pressure cuff, which is also a good thing. And then the last piece, which I didn't mention for as sort of an extended part of our program, is the second piece is that we also have set up a heart health after preeclampsia program with our Heart and Vascular Institute. And we have certain cardiologists who specifically will see these patients, and we try and get them in within 6 months of their delivery, because we know that these women with preeclampsia have a higher risk of cardiovascular disease later. And so we try and get them in for a screening visit. They get screening, testing, education about heart disease prevention, and then they'll get, short, long-term plans for their cardiovascular risk assessment, any reduction in treatment plans that they might have specific for whatever they have going on. A lot of them are young and healthy and don't need it, longer follow-up, but some of them do. And I think when they realize they're also going to see a cardiologist and that this may have longer impact on their health, I think they're also more likely to adopt the blood pressure cuff too, because they realize the connection. So I think I think they're just really happy to not have to come to the office. I think that's mostly the benefit.
I'm not going to just pour on with more yes and.
Sorry.
You know what? I'm going to keep my remarks really brief, because I really do think it boils down to education, free access, which matters certainly to some people a great deal. I think also respecting the importance of good quality devices, not just sort of checking the box that we've given a device, but that it's a good quality device. And then I think the other piece is provider guidance. That's the one piece that might be unique, given the fact that we are working with so many providers across the country, is that we run Cuff Kit Connection, which is a monthly kind of like an office hours meeting, where we just invite anybody participating in the program to come and communicate and talk about what's going well for them, where their challenges are, what kind of issues they're running into. And there's a lot of peer-to-peer sharing and knowledge sharing that way. So that's been a unique feature also of this particular program. But overall, I think that the education and the motivation that you're providing to patients is the key in almost all these programs that we're listening to now, and others.
Yeah, I just wanted to add that, so some of the things we've done is, so we've actually, this program is, I'm exactly like Dr. Jury. It's not even an opt-out. It's not even like an option. It's like when you have diabetes, we give you insulin. When you have hypertension, I give you antihypertensive. When you come here and deliver, you get enrolled into this program where you're going to get a blood pressure cuff. There's like a whole thing. And one of the things we've done is like, it's now in Epic. I'm pretty sure, Dr. Dury, you have it too. So all the things, all these barriers that you think don't exist, they actually exist. So for example, the residents will forget to enroll. So it is a part of our postpartum preeclampsia set. So everybody gets Lasix in our hospital for 5 days based on that Lasix trial. So that's part of the postpartum set. And then we just have to check off RPM program, which is remote patient monitoring. And then the minute they say RPM program, it kicks off these things, the nurse education, the bundle that they have to get, the appointment that they have to be made. I can tell you that I do agree education. We also have a video that every patient has to watch that has me in there saying, so it's kind of fun when I go in there and I tell the patient, have you seen me before? And then they'll be like, no. And I'm like, you haven't seen me before. I talked to you for 5 minutes and 22 seconds on that video. So I think having that personal connection is good. We have those same things. It's not, ours is like automatically connected through Bluetooth, through Epic. But we do have reminders to the patients. We didn't really talk about community health workers, but very recently we have a beautiful program through University of Chicago called Link. So it's a set of community health workers, which is managed through the University of Chicago. So we got connected to them. So we have now several community health workers part of our postpartum hypertension program. So they get escalation emails if the patient is not checking their blood pressures. It's like a 3-day thing. I think it's for 72 hours if they haven't checked. I would argue, though, for all of you guys who are collecting data like me, to look at your rate of engagement after the first 3 to 4 weeks. This paper is, I'm happy to say that our program actually just got awarded by the Joint Commission as a National Award for Excellence in Pursuit of Healthcare Equity. So that's a pretty hefty award we just received. But I can tell you, as part of that, they were like, oh, do you want to submit a manuscript? I'm like, sure, let's look at the RPM data. And one of the things I really focused was, how engaged are the patients beyond that first 3 to 4 weeks? We're asking them to check blood pressure twice a day. I can tell you about 50% of the patients are not checking their blood pressures with at least not even once a week after that 5th week. So it's like, it's been a challenge. And we have about 80% of our moms here are African American. They're usually young people. What we found was people who have new diagnosis of preeclampsia, who missed their postpartum hypertension appointment, who are young, those are the people who are not super engaged after that first 3 to 4 weeks. So obviously, I think we added the community health workers. I haven't not really analyzed that program, but I think it's obviously we all have good programs, but tweaking it to make sure that people are continuously engaged. And Dr. Jury, we did the same thing. We have a postpartum cardiac clinic. So we obviously educate our patients, tell them about long-term cardiovascular risk, and then connect them to cardiologists. So those are great strategies that everybody is using. It's fantastic.
And I would say, to echo what other folks have said, make it easy for patients and make them feel engaged and part of the process. So, we make it easy. It's on their phone. It's a text message. They don't have to log into a different app or things like that. So for them, it seems like just texting a friend when you text in these values. So that we think has been really helpful. We have everybody do a virtual visit at the end of their 10 days post-discharge with our midwives to kind of review what happened and where they are. And then the midwives send their note from that visit to whomever is going to see them from their postpartum care, be it their primary care physician or their treating obstetrician during their pregnancy, to just make sure there's that continuity from what happened in the hospital in the postpartum period to the next step of their care. So I think just taking as many burdens away from the patient as possible has been what's helpful for us. And patients have, really appreciated it and almost been tearful that they're able to do this at home and not in the hospital.
Would people also add that advertising and at least what we found in our labor and delivery, putting all this data, and I frequently print all our papers and I tell the nurses, you see, this is all the hard work that you guys did. Look, we won this award. I think that also makes the patient feel that, this is something that this hospital, so, these providers are so passionate about. I think just talking about preeclampsia and hypertension and whosoever you can find, I find that very helpful too for the patients, and hear it from different providers at different points, sometimes the residents, sometimes the nurses, sometimes the postpartum nurses, my research assistants, me. I think I find that helpful for the patients. And you're right, like the minute they check the blood pressure and there's an escalation, within some of my patients say that before they can literally even take off the cuff, somebody's calling them from the HRS portal and saying, your blood pressure is severe, you need to do X, Y, and Z. And then they're like, oh my God, like I'm barely just got my blood pressure. So I think that kind of positive reinforcement to the patient is also helpful, I would see, to have continued engagement in any kind of program.
And Dr. Rana, you kind of just touched on our next question some, and it's been a common theme throughout this panel so far, but how are you helping patients incorporate the readings directly into how they're receiving their care? And using Bluetooth-enabled devices to do this has been something that's come up multiple times throughout this panel. Are there any barriers to using this type of platform, such as digital literacy, or does this require patients to learn new technology postpartum to interact with and download into the medical record?
I can tell you our program is very simple. It's an app. So I do agree, Dr. Langen, they have to open the app, but it's on their phone. It's a very simple app. We actually, when we enroll the patients in our program, we go through so we have them, obviously give them the blood pressure cuff, teach them how to take it, but we also download the app with them and then have them check a blood pressure in front of us so that they understand, if I check the blood pressure, this is how it's, okay, I open my app and then the blood pressure directly transmits into the app. They can actually see what their blood pressure is. And there's a little click that says your blood pressure is fine or not or high, just so that they can get a little instantaneous feedback. And then we open up the Epic in front of them and say, look, you just check your blood pressure. It's here with me, so I can check it anytime. So I think we definitely do that. So I haven't really heard any, there are people who are checking, like I said, it's a high proportion. It's about 96, 98%, it's in our paper, of the people checked at least one blood pressure when they were giving the cuff. So everybody, pretty much checked it. I don't think it's a technology thing. People are pretty savvy. I feel like they are used to apps. It's pretty compatible with all kinds of phones. I would say there's some drop off, at least in our patient population, just to check the blood pressure. So it's not between checking and transmitting and then the provider getting. I think it's that first step of them actually checking. Especially, I feel like patients who have normal blood pressures at that 7 to 10 day visit and they're not on antihypertensives, I think they kind of fall off the grid in terms of checking their blood pressure. But then do they really need to check the blood pressure? That's my second question that I'm going to ask out of my own cohort. But I would say that at least in our hands, in our system, I haven't really seen many barriers in technology per se.
Our program actually doesn't have an app. They just actually, in the kit, they get a modem that gets plugged in at home. And their cuff just has to be within a proximity to this to transmit. And then the patients, the CARES program that we have, somebody contacts the patient after they're home and sort of does a formal enrollment phone call, make sure that they're using it right. They do the first reading from home on the phone with them to make sure that it does transmit, and they kind of make sure that's all correct. And on occasion we do, these are validated cuffs, but on occasion we get a weird reading where you'll have some, like a really narrow pulse pressure, or something will seem strange, or the patients will have had great pressures and then they seem off. And actually they have text that we can actually ask to be sent out to the patient's home, and they will go out and they'll check the cuff and they'll check and make sure that it's working correctly and that they're using it correctly. And they actually they'll go the same day that we ask them to go out. And so we can kind of correct things. And sometimes there's something going on with the cuff and they actually will replace it. So at least we sort of have that to fix things. That doesn't happen that often, but it is an availability if needed. And the patients are educated. Their education piece, they do get information about what to do if they have super high blood pressures and the warning symptoms, in the event that they have a reading and somebody hasn't contacted them, in a short period of time, they at least have that education to, they have a phone number they can contact, or if they need to go to the hospital, for evaluation as well.
I don't really have much more to add. Ours, we haven't really found that issue either. Our readings are uploaded through the My Ochsner app, which is the same place where the patients can send messages, they get their labs, they schedule their appointments. So they're all familiar with the app itself. And so it's not an additional app. And so we haven't really found that to be a barrier. I will say, as part of equity, urban rural equity and racial equity, we've just partnered with Tulane and RH Impact on an NIH grant to look at our program in some other rural areas of Louisiana. We've looked at our digital hypertension program for the general population in some rural areas, and we've seen improvement in blood pressure control, compliance rates, satisfaction rates higher than usual care. And so we're trying to replicate that same study in the rural population of pregnant individuals to make sure we're seeing the same thing.
I think that all sounds great. Like I said, I'm impressed with all these fancy apps. Ours is just literally a text you and you text us back. So
I think they all work. I think the message.
I think it's nice to see like this variety that patients.
I mean, I think if you educate the patient and you give them resources, which are, like somebody was saying, they should not be barriers, but they should really be easy. It's easy to understand. It's easy to apply. It can be applied to everybody. So we don't push the burden of make your own appointment, go get your own blood pressure, figure it out. If your blood pressure is high, you have to call 5,000 different numbers. And, I think the message is that I agree. I don't think it's the app. I don't think it's I think it's the fact that there's a structured program around a certain condition that people can find it easy to use. I think that I agree. It's all equally effective.
Mm-hmm.
I don't know how we're doing on time gauge, but I did want to, I'm just going to throw this into chat for anybody who's watching this who doesn't necessarily have one of these beautiful self-contained programs that our panelists are talking about today, and who just want to use some of the education materials that we have on our website. I'm just throwing the link in chat, because anybody, I mean, again, I think one of the common themes that we're all reflecting on is that patient communication and helping them to understand the importance of measuring blood pressure during pregnancy and after pregnancy, using good quality information and educational materials that's culturally appropriate, language appropriate, really follows good patient-centric, patient education strategies is really kind of the key to it. And people can go to our website and just pull that down for themselves if they're watching and don't have a formal program in place.
I can also add that we do Eleni, you want to say that? I know Eleni for several years, and we were partners on that paper that she talked about, the cuff kit. We never used the cuff kit because we had this program that's already funded. But there is we can get all these resources for free from the Preeclampsia Foundation website. You just have to I think pay for the shipping. So the tear pad sheet that she has, it says you are still at risk, that actually goes in my bag. So I have an actual bag that I give to the patients that goes in that bag. And then the bracelet, the one that we are also giving, which says postpartum preeclampsia, it's like a purple bracelet that we bought, is super cheap. It's I think 2 cents. That also goes in that bag. So a lot of educational materials that are available on the Preeclampsia Foundation website are actually, most of them are free, right, Eleni? Is that correct? And then people can order them?
I would say virtually free, because there is some shipping and handling associated with it, but relative to what you'd be buying, in retail, they're very inexpensive.
And they're all validated, and they're very patient friendly, and they're very visually appeasing. So you can actually just literally, you don't have to rediscover. We didn't discover any of that. We just took all the materials that were available from patient education from Preeclampsia Foundation and started giving it out to every patient. That was very, very helpful to just kind of start the program.
Yeah. And I think one of the keys that all these programs show is just the care and attention that patients get. We we did a survey. We sent flyers out to different physician organizations and did just an interview survey of women across the country who had had hypertensive disorders of pregnancy. And, it wasn't a random sample. It was people who wanted to talk and share their stories. But one of the most common things that I heard from folks who were unhappy with their care is that they just felt abandoned afterwards. They knew something bad had happened to them. They knew something dangerous had happened. And then no one told them. They didn't know how to get in touch with people. Some folks went to an emergency room rather than a labor and delivery. And that sense of kind of abandonment from the healthcare system is really what stuck with a lot of folks. And so I think one of the unifying things of all these programs that I encourage people who are developing a program to think of is really just, how do I make people feel cared for, and that our team wants to keep being engaged with them. So even if it's like a phone call or really low tech, whatever it is, making sure that people know that you care and that they know how to re-engage in the health system. To me, I think that's the most important link that connects all these programs.
Yeah.
Thank you. And you are all, or most of you are providing blood pressure cuffs for your patients. But what barriers to obtaining validated blood pressure cuffs exist for those who need them? And how have you overcome them to provide those cuffs for your patients? And what can others do to overcome them in your communities?
I mean, I think at least antenatally, I will say, with what Elizabeth was saying, blood pressure cuffs, at least where we are not covered by insurance. I would love to know how you're getting them covered where you are, because that's awesome.
Yeah.
Honestly, that is a big thing. And that's why, for patients who then have repeat pregnancies, they can potentially hang on to their blood pressure cuff if they've been in this program, because it'll still work.
Mm-hmm.
But I think that is a big barrier, honestly.
And it's hard.
These programs are helpful.
And
then, we've actually, I think where we are, some of our lower income patients, in our area, we have, I think we don't have any currently, but in the past, I think we have actually distributed some antepartum blood pressure cuffs from the Preeclampsia Foundation to some of the patients who needed them. So, I think utilizing that resource is probably one of the best ways to overcome that barrier, honestly.
I will say, can I just put a plug in? Because I know one of you all were talking about how the component to this is the advocacy piece. And I really think that's what all of these programs really need to be pointing to, is that, I keep telling my team, I'm like, we're not going to be in the fulfillment and distribution business of cuff kits forever. What we really need to work toward is that this is such a payer covered standard of care that ACOG and SMFM and all the healthcare societies are driving toward, and that the payers are covering them, and that this is just the new way that you get through pregnancy, that you're given a blood pressure cuff. And after pregnancy, you're given a blood pressure cuff. This is what we need to work toward. And I think all the research that you all are doing, the programs that you all are operating, please, if you're not already tacking on a research component to it, and I know Dr. Rana certainly is because we're working closely on that, please collect data and that can accrue to the improved outcomes that we're seeing. I'm super excited about, some of the data that you guys have even shared already. That's what we have to work toward, because I can't even, because we're working this as a national program, I can't tell everybody the same thing because every state is different. There are some state Medicaid programs that are covering. They do have a CPT code for the devices, for the education. Others do not. And so we need to get to a place where the entire country, both for private insurers as well as our public Medicaid programs, are covering this device and the education that goes with it.
So we actually have an issue. So
what I was going to say was actually very, very similar. So Dr. Langen, to your point, in some of the work that y'all have done, I worked with our state Medicaid to get it covered as well. And so I think that, and I do public health and policy work, and so I probably have a different lens. I think that each of us has more power than we realize that we have from a policy standpoint. Our legislators want to know how to make it better. They just need people to tell them because they're not on the roots on the ground. And so each of us has that power. And, this was just from talking to our legislators, talking to state Medicaid, them showing them, Dr. Langen, like you said, showing how this is a cost savings when you do invest in programs like this. And so, and as you said, Alini, there's work that I know I've done on the congressional level from a national level, but the majority of the patients that will not have access to this are the ones that are covered by our state Medicaid. And that's going to be different from state to state. And so all of us doing this work, or anybody that is hearing about this work, talk to your legislators and talk to your state Medicaid.
So I was going to say,
go ahead.
And so in addition to the blood pressure cuffs, our remote monitoring services, when we first started the program, it was actually not, the patients were not being charged, but because it's such a big program and there's so many other parts to the program, they actually now do bill the patient's insurance for the remote monitoring services, and it's based on time and things like that. And it's not a huge amount of money, and most of the patients don't have any problems with it because it's not a huge amount, but the medical assistance plans don't cover it. And so for some of our areas now where we've expanded our program, where they have a higher proportion of patients on medical assistance, we're actually right now, until we figure this out, because we're working on getting the data to take it to the payers, we're actually using some of the award money from this to cover the difference for those patients who won't otherwise participate because of the cost barrier, which is really frustrating. And because, we're hoping to, in addition to looking at the benefits to the program and the good outcomes, we're actually going to take the patients who declined to participate and actually compare those outcomes to the patients who were enrolled, where we have IRB approval. We're just collecting the data now. And then the people who run our remote monitoring program are going to work with us to hopefully take this information to the payers to actually get the remote monitoring system and program covered, because I think that's that keeps patients out of the hospital as well. I don't know why they wouldn't want to cover that, so I almost feel like it's even bigger than just the blood pressure cuff. So that's sort of, a bigger piece of the puzzle, but that's where we're at in terms of the monitoring part.
I think the other thing for you guys can all do, and I think it's going to take some time, but I read a paper I think it was from the group at UPenn, is that they looked at their Medicaid data, some sort of not a patient-specific data, but to look at long-term outcomes. So even if enrollment in this short-term program that they had for 10 days, I think their program only runs for 10 days, had an impact on the patient's blood pressures and everything, like for a whole year. So I think definitely convincing payers is a hard task. I have to tell you, Dr. Dury, that the way, and every system is different. So, and I'm still struggling with pregnancy because, the obviously CHAP and all that is out and everybody should be controlling blood pressures, but nobody's blood pressure is being controlled because there's so many barriers. So perhaps doing remote patient monitoring in the antepartum period is the way to go. So we are actually we went and talked to the HRS people and we said, can we just move this program entirely in the pregnancy? And can you do remote patient monitoring for 10 extra weeks or 20 extra weeks of, 30 extra weeks, besides doing the 6 weeks postpartum? And they are like, yeah, we don't really care. Obviously I have to create escalation protocols because they're different during pregnancy or postpartum. But at least at our institution, I don't know how long it'll be funded, but I was really able to get in front of a lot of kind of higher level leaders and tell them how important this problem is. And there's so much press out there for, obviously mortality in women. So I just kind of play it up a little bit in terms of saying, okay, what are we doing as an institution to reduce this? What are we doing? We are big institutions, we have a responsibility. So that got me quite far. And now it's just being funded by the IT as one of the things that they say, yeah, we're going to fund this program because it's a good program that makes UNICEF Chicago is doing its part. So I know every system is different, but obviously it'll be great if payers are paying it. But I would really push people to kind of look internally, talk to your chair people, talk to your chiefs, and kind of figure out. And then, we used a lot of HHS money just to buy blood pressures. I have an office in front of my office, which is literally full of blood pressure cuffs. So the person can't get a blood pressure cuff from anybody. I'm just going to give it to you because I have it. So I think just creating some of these kind of channels in your own institution and just talking to your chairs and higher up people can also get some resources to our patients.
Well, thank you all. This has been great. And it's just been great to hear you share on how you've successfully gotten blood pressure cuffs into the hands of women and outlining some steps that others can do to do so in their communities. I will now turn things over to Lieutenant Abayomi Walker, who will lead us through another interview from a patient perspective that has worked to control hypertension in her own life. Thank you.
Good afternoon, everyone. I'm Lieutenant Abayomi Walker, and I'll be interviewing Ms. Ali Khani about her experience with hypertension. So your mic should be open now, ma'am.
Yes. Hello, everybody. It's great to meet you. Thank you for having me here today. This is such an important issue, and I'm just so happy to be able to share my experiences because it seems so simple, but it's still out of control in our communities with a lot of people, and a lot of them are in my family and friends, so I know about this firsthand.
Okay, so can you tell me a little bit more about your own individual story? Maybe if you start us from when you were diagnosed, or maybe since you, sorry, let me adjust my volume. Is that better?
Yes, it's fine.
Okay.
Fine here.
Sorry, someone in the comments.
Mm.
But back to your personal story, if you could share maybe how you were diagnosed and perhaps maybe what your personal awareness was, since you said you do have a family history.
Yes. Well, I never thought I would end up with high blood pressure. Okay. So it really surprised me because, in my younger years, until I was diagnosed with high blood pressure when I was like I started getting it when I was between 30 and 40. I had always had low blood pressure issues. So I thought, and I had always heard my grandma and my mother and a lot of relatives and my aunts talk about high blood pressure. And I thought, oh God, I don't have to worry about that. That's something that's going to happen to you probably when you get really much older. But it happened to me earlier. It just sort of crept up on me. And I live in Los Angeles, and, I'm a heart patient. I'm a heart and stroke survivor. And, but I was born and raised in the South, in the rural South, and in Arkansas. And high blood pressure issues and things like diabetes, which now I'm diabetic, really rampant in those areas. And so, I wasn't really planning or paying attention to this issue of high blood pressure. And I think, being from the South, I love good old-fashioned country style cooking. I love to eat delicious food. And so I brought all those great habits with me to Los Angeles when I came out here to go to college when I was 18. And I just kept on doing it because I used to be really active, exercising and everything. And so I didn't have that problem when I was younger. But later on, it caught up with me. Lifestyle caught up with me. I became more, as I got older, exercising less and just enjoying all those comfort foods, all those good comfort foods. And so now I have high blood pressure. And it's been quite an eye-opening journey for me because I have to be really diligent about this issue. And it's something that I realize now it requires a lifestyle change. And it's something you have to work on and be prepared to sustain all your life because you have to keep your eyes on the ball. And so when I was misdiagnosed with a really rare heart condition in 2008. And that is the time when also I started being more proactive about heart health. And I wanted to learn as much because they scared me to death when I was diagnosed because it's like a condition that's really rare. And I was born with it. And all these years, the doctors had been saying I was fine, but, you need special training to know how to diagnose the condition I have, you need special testing, expensive testing that often insurance companies balk at paying for. And so I used to pass all the routine tests, but yet I had this high blood pressure creeping up on me. And so now here I am today, and taking blood pressure meds and working on my diet and exercise regularly.
Thank you for sharing that. A couple of things I want to kind of dig into a little bit more with your personal story. You were diagnosed, you said in your 30s or 40s with the hypertension?
I was, when I was diagnosed with a rare heart condition, that's when the hypertension was diagnosed as well. And that was around 2008. And I think I was around 30, I was 30 something after mid 30. Yeah.
And because you said the condition was rare, did you get that diagnosis of the hypertension and the congenital heart condition from a specialist, or was it your primary care doctor that picked it up?
I got it from my cardiologist. What happened was, it happened ironically. My husband had a heart attack, and he was tossing and turning in his sleep. And I woke him up and took him to ER. And of course, I know now you shouldn't drive people to ER. You should call the ambulance because they can save you on the way to ER. But I took him, and they saved his life. I got to ER in the nick of time at like 12 midnight. And after that was when I realized that chest pain matters, and you need to pay attention to heart-related symptoms. And that was the first time I started even thinking about heart disease symptoms and learning the symptoms. And I joined advocacy groups. I joined Women Heart. I joined the American Heart Association, and I was just all over their websites collecting info. And so after I saved my husband's life, then I started paying attention to my own symptoms. And then I went back to ER, and I said, I don't feel right. And I know my husband had issues, and they thought he had indigestion, and you ended up saving his life here. So I know you can save me. So I'm just going to stay right here with you because I saw you save his life. And they said, well, you passed all the tests. They gave me all those routine things like, EKG and, just basic stuff. And everything seemed fine. And I don't know what got into me. I just refused to leave ER. I just said, I know you can help me. I don't feel right. And, you have to be persistent because it paid off for me. And that ER doctor said, well, there's one test you can take, but we don't have it here at the small community hospital down the street from my house. He gave me a prescription. Lucky I wasn't dying at that moment. I took it to my doctor at UCLA, and they ordered a stress test for me. And that's when they discovered my rare heart condition. And that's when I learned that high blood pressure and all these issues are really, really serious. I mean, my husband's blood pressure was soaring in the 200s. We didn't even know it mattered because at that time, we weren't going to the doctor regularly. We were just going to the doctor when we felt bad. And even though, after my husband, I got a cardiologist, I still wasn't really like in sync with symptoms and issues the way I should have been, and the way I am today. So that cardiologist, my primary care doctor and my cardiologist got me diagnosed. And that's how, I got to where I am today, being more proactive about my healthcare, my high blood pressure.
Okay. Thank you for clarifying. Can you tell me some of the symptoms that you were experiencing? Because you said you went to the ER because you kind of had like this increased awareness after your husband's experience. But what symptoms were you experiencing where you kind of were feeling like you needed to advocate for yourself further beyond the initial testing?
I was having shortness of breath, and I wasn't that old at that time. I was having a lot of shortness of breath, and especially upstairs at my house. When I would go up the stairs, I would get it a lot when I would walk really fast, and I noticed that a couple of times at the airport when I was rushing, had a lot of problems at the airport, and I had to get a ride on one of those little carts. It was really embarrassing. I thought, oh my God, what's wrong with me? And I also, when I would get winded, I would have this little pinching feeling in my chest, around my heart. I would have actual physical pain around my heart when I would get winded. And so I knew that something wasn't right, because I remembered my husband having, shoulder pain and back pain, and they just told him that he had indigestion and he took Tums. And I thought, oh my God, he almost died, because they told me they saved him in the nick of time. He had just a few minutes to live. He was dying in front of me. So I thought, I'm not going to take any chances. That was, God's warning to me. That was my wake-up call. He gave me a second chance. So I saved my husband, and ironically, in return, that saved me.
Okay. So you've talked about the importance of being aware of your body, how you actually feel in your body. You mentioned the research that you did and organizations that you joined subsequently after your husband's cardiovascular issue. So I want to kind of bring us a little bit more into more recent times with you. Your care team, can you talk about your care team and kind of how you all integrate together along with yourself, like how you manage your hypertension?
Okay, well, and first, I also want to mention that, that ER doctor was a man that told me that everything I was thinking was my imagination because of what has happened to my husband. And that kind of really upset me a little bit, because here we go again on this thing about women and their imagination. Mm-hmm. And so I just kind of, in my mind, I thought, you know what? I'm just going to stand up for myself, and I'm going to help myself and be proactive about my own health care. And so now I have a great care team, and they really listen to me. I mean, these days you hear a lot about improving patient-centered care and all that. Some of it's talk, but with my care team, it's real. I mean, they actually listen to me, and they work together. That's not easy to do, because I remember the days when my doctors didn't even know each other. They were at different facilities, and it was difficult for them to communicate because the medical records were not linked together. So one doctor cannot see the other doctor's reports and records. And so there's all that info, all my patient-reported outcomes not being, fully taken advantage of because of the technology issues. Now my team, they know each other, they communicate with each other because my records are linked. And so each doctor knows what the other doctor is doing. And it's not only important because I have a rare heart condition, it's important for everybody, because you need to make sure that what you're doing is not conflicting. And so they really listen to me. And I really appreciate that. And anything I'm concerned about, they take it seriously. And I didn't always have doctors like this. And I just encourage people that when you're not getting the answers and responses that make you feel comfortable, you should feel comfortable. If you're not, just keep on going and keep on checking with other people and getting other opinions until you're satisfied. Don't be afraid to do it.
I like that you said that, the point about one, advocating for yourself and continuing to advocate for yourself until you get the response that you believe you are deserving of. And the importance of having a care team that not only communicates effectively with you as the patient, but also communicates with each other so that everyone understands what is happening, again, with you, the patient. So I really like that. I think it's important, and I really can't stress it enough, that as healthcare providers, it's really important that we are integrating the patient into their care and that they're a vital part of the healthcare team and planning that goes into taking care of the patient. So I really appreciate you saying those things. Are there any challenges that you currently experience related to controlling your hypertension?
Yes. At the beginning, one of my challenges was my insurance deductible was high. And so you would think, I would think twice. I would be like, okay, I'm going to go get checked as soon as I meet my deductible. I feel okay. It should be okay. That's not a good idea. But, now I don't have that issue anymore. I'm dealing with me. I have to get out of my own way sometimes because, like most people, life is hectic. We get really busy. And sometimes I am not really doing, I have medications and I also have a diet and exercise program. So it's not just medication. You need a whole lifestyle change to deal with high blood pressure. So watching what you eat, and by diet, I don't mean some big crazy diet that you can't stick to. I'm talking about eating a balanced diet, eating balanced, every day, not overdoing it on anything. I mean, I'm not perfect. When I get stressed out, I like some chocolate cake. I probably shouldn't be doing that, but I'm just going to admit it, that a bite or two is not going to kill me. My doctor told me. So I can have a taste of little things here and there. But sometimes I can go overboard when I get stressed out, when I get really busy. And sometimes I'm going to be honest, I sometimes forget to take my meds on time. And if you get swamped, with things to do, it's easy to forget. But it's good to be upfront with your doctor. When you see your doctor, don't be embarrassed to tell them really what's going on in your life. And because they can help you with that. Because if you're not being honest with your doctor, then they don't know how to adjust your meds and how to really give you the best care because they don't know the truth. So, this trust factor is really, really important. It's really good to have a good relationship with your doctor that you can, be honest with. And my doctors know me, so they don't scold me, but they're very persistent and they're very adamant about it. They just say, we just love you. We care about you. You want to be around a long time. So you've got to be diligent. And so I'm trying to work on and stay on schedule by doing everything at the same time, around about the same time each day, because that's really helpful. Because if you can do that, it really helps to stay on track. And also just walking a little every day. I have to admit, I'm not good at these great big exercise routines that, these, weekend warrior things and these big things that are hard to maintain in your life. But I'm good at simple things like walking and just a little movement. And just doing a little bit of that every day, it helps me feel successful to do little things that I can keep up with. So these are things that are very helpful for me. And these are the areas that have been the biggest challenge for me. I'm a big believer in epigenetics, that you can change your DNA with what you eat and some movement. And so that's what I'm trying to do these days is keep working on that and never giving up. Just keep on going. Whenever I fall off the wagon, just get up and try again and spread the word in my family, because my family now, they're mostly still living in the South, and they're still loving all that good old Southern cuisine and dealing with the similar issues. Excuse me. So, excuse me, sharing and exchanging information with your family members is really important. And I do it at our family reunions. I mean, I really get on the nerves sometimes, but I do it anyway because it's good. You know, it should be part of the fun at the family reunion, like everything else. And, you know, I borrowed a slide presentation from my doctor, and, you know, I did a whole presentation at my family reunion. One of the biggest ones was in Las Vegas, and they thought they were going to have fun in the casino, but they had to listen to my lecture first. But it was life-saving, and it was worth it.
That's great. So that brings me a thought. So you said you have this family history, right? And your husband also has some health issues that were related to his heart.
Runs in his family too.
So you both have family history, and then you both have your individual diagnoses. And so I wanted to know what if you knowing what you know now, right? The experiences that you have had, family members have had, your husband has had. Is there anything that you would that you would advise others to do to try to prevent or even offer better control of their hypertension with the experiences that you've had?
I think it's really important to use that thing called a blood pressure monitor regularly at home. And that's something my cardiologist always reminds me of. Get one of those and use it. And, excuse me, know your numbers. I mean, every year, around about this time of year, you hear a lot. I mean, my husband's company is just overwhelming us with know your numbers, your wellness checkup, your annual wellness checkup. And they made it even easier for us because they give us this big discount if we do all these little procedures for the Know Your Numbers program at his company. And so it really helps, and they give you feedback too. And it's something that keeps you on track with your numbers in addition to going to the doctor, having a cardiologist, having a primary care doctor, excuse me, that you see regularly. That's very important. And to keep track of your numbers at home, and when you go to the doctor, take those with you so that when you see rises in your blood pressure, that you know that sometimes it can be related to, stressful incidents that, pop up here and there. But if it's going on when nothing incredibly stressful is happening and your blood pressure is constantly up, I mean, that's serious because, it's one of those things that, like they call the silent killer. It can lead to stroke and a heart attack might be looming. So it's very important to pay attention to the numbers and monitor and keep track and, see if you can see any patterns or triggers that affect your blood pressure so that you can try to stay on top of things as much as possible. Excuse me.
Do you want to get some water? Great. Can you talk to us about any emerging resources or programs or technology that you utilize to help control your hypertension, things that you find helpful?
The best technology I can think of is a blood pressure monitor. And I know these days, there are a lot of apps out there where I just write down my numbers in my, own little journal. And I keep a tablet that I keep everything, my to-do list in every day. And I just write my numbers in there, but there's all these fancy apps and things that you can get, and you can use those on your cell phone. And they're pretty simple. I've checked out some of them. And just keeping track of your blood pressure that way is really helpful. I also have to keep track of my diabetic numbers too. So it's good for me to do that. So blood pressure monitor, and, as a diabetic, I have, monitors for that as well. And, but I like to keep it simple, and I like to just write things down. And that's what I do, and that works for me.
Okay. Ms. Ali Kahani, thank you so much for sharing your experience with us.
Thank you.
I just want to recap a couple of points that I think would be helpful for other women who are listening onto the call. You spoke about the importance of knowing your own numbers and sharing it with your provider. You talked about the importance of finding a care team that believes in communication with the patient, and not just communicating with you about the plan, but also listening to you as a patient as to how you want to manage your care, what symptoms you may be experiencing, what lifestyle changes you are carrying out. And so the importance of also advocating for yourself. If that means requesting additional testing, if that means going to see another provider because the provider that you spoke to is not fulfilling the care that you believe that you need, also really important. And then the other thing that I think you also spoke about a few times was the importance of lifestyle changes that are going to be easy to be consistent about. And if you fall off the wagon of your lifestyle activity, don't beat yourself up. You can start over again later that day or even the next day. And a few bites of chocolate cake never hurt anybody, said the cardiologist. Okay. So we thank you so much for your time. Everyone will be wrapping up, and I believe we will get pulled into the larger group from this breakout session. Is that correct, Gage?
Yeah. Thank you, Lieutenant Walker, and thank you, Ms. Alakahani. What a great way to cap off our time here today, hearing about your story. It has been wonderful to hear from each and every one of our panelists and presenters today who discussed a wide variety of topics from their community initiatives and how to partner with your community, how women and providers can work to control hypertension through behavior change, on the importance of CPR and how we can be equipped in emergency situations, and on self-measured blood pressure monitoring and why it is vital to hypertension control, as well as how some have gotten blood pressure cuffs into the hands of women to help with the adoption of SMBP in their community. Thank you to everyone who joined us today for the 2023 National Women's Blood Pressure Awareness Week Summit. And we hope you can take away the information shared today and use it to improve hypertension control in your communities and lives. Have a great rest of your day.
Produced by the U.S. Department of Health and Human Services.